Wait a little longer. Atrial dysrhythmias. Are we panicking?
No.
No. What's the worst case scenario of an atrial dysrhythmia?
Clots.
Clots
Stroke.
everywhere, right?
Oh.
Yeah, I think stroke, yes. So A-Fib is one of the leading causes of stroke because when you have something wrong with the atria,
It pools.
that blood just
pools
sits. Yeah, and any blood that sits,
Clots.
yes.
Mm-hmm.
So it's something we would worry about for the future, but nothing is like acutely happening right now because the ventricles are still like they're going strong, right? And even if the atria is fibrillating, the valves are still opening and blood is still coming down.
It's just not great.
It's just not awesome, but the ventricles are like, that's okay. I'll just pump a little harder. That's why there's no signs of poor perfusion and everything will look good. And most people don't even know they're an A-Fib. Okay. That's why your Apple Watch will tell you because you didn't know. Y'all know what I'm talking about? Cool. All right. The first thing we're going to talk about is premature atrial contractions. What are PACs?
A premature atrial contraction. So the atrium contracted.
I feel like I'm so stupid. Okay. Well, you teach me then.
Is it extra like waves that you see?
It's an extra boop, right? And what would cause your ventricles, like, I mean, your atria, like, you know, they're supposed to be like bum, 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 like that.
Excitement.
Yeah. Yes. Like anxiety, like caffeine, something is making them like
jittery.
Yeah. So like stress, excitement, caffeine, tobacco, like something is just like, they're so excited. They can't wait to beat that they just, boop, you know, and give us a little extra. Are we panicking?
No.
Oh, what's our heart rate?
It could be anything.
No, it's normal.
Yeah.
Right? Because it's not even like, it may not even blip enough for it to count as like an atrial beat. And even so, the heart rate, we count the QRS complexes.
Right.
That's ventricular rate. So their heart rate will be
60 to 100.
normal, right? Their PRI is going to be
0.12 to
0.12 to 0.2. Their QRS complexes are going to be less than 0.12. Everything, are they stable?
Yeah.
Yeah, but it can lead to A-Fib. So it's something that we need to watch, right?
Mm-hmm.
But they're stable and ain't nobody that excited. Okay, what's the first thing you need to do? What's your priority for PACs? They're not going to have poor perfusion.
Calm them down.
Yeah. So we're going to calm down. We're going to find the underlying cause and we're going to be like, it's okay. I mean, you can't get fluids, but we won't, you know, I mean, it's just kind of, you're just going to tell them, hey, make sure you're getting plenty of sleep. Make sure you're hydrating really well. If you're smoking a whole lot, you need to cut that down. If you're drinking a bunch of caffeine, like cut down on that. That's probably not effective, but you're going to tell them that anyway. Do you understand?
Yes.
Okay. Now let's go to A-Fib. What's A-Fib mean?
It's not contracting.
So the atrias are just like, right? But the valves are still opening. The ventricles are still like doing their thing. So our biggest risk with A-Fib is clots. Okay. So what does their heart rate look like when they're in A-Fib? It's not going to be normal because the atria are fibrillating now. So it's actually going to count as a heart rate.
So you're kind of tacky.
Not kind of tacky, like 300 to 600.
Okay.
You realize it's fibrillating, which is going like
How
this.
does that make? Isn't heart rate QRS complex?
It is, but their heart, like when you pick it up on an EKG, like if I counted their QRS complexes, their heart rate may look normal, but if you actually look at it on an EKG, it will still count that atrial rhythm. Okay, so like turn it over. You can turn your paper over for a second. I'll show you what I mean. Okay, so an atrial fibrillation, you can see, do y'all see the P wave?
Yes.
But then you see after the P wave, or like, honestly, you can't really even see the P waves because that's a T. Look,
that's a yeah.
that's a T. So let me see if I can focus.
So there are no P waves.
No, there are, I mean, there's tons of P waves, right? But they're just like little blips, right?
Okay.
So it's going to go like bzz, boop, bzz, boop. So if I counted QRS complexes, right? I mean, yes, it's going to appear as if the heart rate is normal, but sometimes it will still pick up on the EKG as their heart rate when it's fibrillating. So it may look like this on an EKG, but when it pops out, you know, on EKG, it'll say like heart rate, you know, it may say like 320. Do y'all see what I mean?
Mm-hmm.
So if y'all see that where the QRSs are like normal, but you're like, their heart rate looks super high, then you're like, oh, well, doy, it's, yeah, A-Fib. Yeah. Do y'all see what I'm saying?
Yeah.
So it's going to go bzzz, like it's like a pager is what it's going to look like. You all clear? But you can see the QRS is beautiful and you can see the T waves are beautiful. Yeah. Oh, someone's having a bad day. Okay. So turn it back over. What would their PRI look like?
0.12, 0.2.
But they don't have
No,
They don't really have, they have tons of P waves. So you can't really tell like where is the P, you can't measure it because you can't tell where the actual P wave is because it's just going bzzz like this. Y'all see what I mean?
Yes.
So you can't measure it because where do I measure it from? This P wave or this P wave or this? So it's not measurable. Y'all get that?
Yes.
Okay. QRS, what are they going to look like?
Less than 0.12.
They're going to be normal. Sometimes they'll be a little more narrow just because your ventricles are trying to like, pump off a little faster. Yeah. All right. Is this patient stable?
No.
Stop looking at my face. Yes, they are stable, y'all. I just told you we don't panic, right?
Yes.
They're considered are they, and we have to do something? No, most of the time they don't even know. This patient could come in for something totally different. I'm like, oh, well, the doctor ordered an EKG. And I'm like, oh, sir, you're an A-Fib. He's like, oh, right. So are they stable?
Yes.
Yes. For now. Okay. And this heart rate is going to be what we call irregularly irregular. Okay. So you're going to see the same pattern, but it's an irregular heart rate. Like turn it over for just a second. Do y'all see how it's like beat, beat, beat? Those look pretty close. The first three look pretty normal. And then you can see it's like beat, 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 beat. Y'all see that? Okay. So, but you'll hear the same kind of pattern. So irregularly irregular means it may go something like this. Beat, 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 beat. So it's the same pattern.
So
Irregularly irregular means like there's still a pattern to it, but it isn't a regular heart rate because it's not going beat, beat,
I
beat.
thought irregular was like chaotic.
No, it doesn't have to be chaotic.
Irregular.
Sorry, what?
I thought irregular was like chaotic. Like there is no like.
It doesn't have to be chaotic. The P waves would be chaotic, right?
Okay. So
Y'all
you're
see-
looking at the whole thing.
You're looking at the whole thing.
Got it.
Do y'all see what I mean?
Mhm.
Okay. So it is regularly irregular. The causes would be, oh wait, don't look at the causes. Sorry, turn it back over. Why would people go into A-Fib? Oh, cool.
Could something be wrong with the NSAID?
Not usually, because it's still, I mean, no,
Anxiety got too high.
it's not usually an anxiety issue. Y'all know, like elderly clients go into A-Fib all the time. This is usually they have some kind of heart disease, right? No, you don't know. So I'll tell you. Okay. So this is either a problem like with the valves, maybe their valves don't open and close correctly. Like if they had stenosis or something like that. Right.
Mhm.
And so it's like the valves are trying to like open, but the atria is like, hey, you're supposed to be open. You see what I mean?
Mhm.
Okay. So you could have like valve disease. It could be stress or stimulants too that can cause your atria to get like really excited. Hyperthyroid can sometimes do this, right? If you're unmedicated. Yeah.
Yes.
Okay. OSA does this. What's OSA?
Obstructive sleep apnea.
Obstructive sleep apnea. Why would they have AFib?
Because you face out.
Hmm?
Why you face out when you stop breathing?
What do you mean freaks out? Tell me more about that. You're like, that's all I had. Thank you.
Yeah. I guess because you're not breathing, so then your heart wants to pump faster.
Okay, I can agree with that. So if they, in OSA, obstructive sleep apnea, right, they have periods of apnea. And so your body may try to compensate by, but it may not be communicating the top and the bottom. Who normally, what is the most common patient population to have OSA? Obesity, right? Which usually comes with other comorbidities and things like that. So the atria are like overly contracting, but it's not communicating for some reason with the ventricles. So the atria just kind of go crazy. Okay. All right. What is your priority? Let me ask you this. There are two different priorities depending on if I see them go into it versus if I do not see them go into it. Right. So if a patient just, came in and was like, hey, my chest has been feeling kind of weird every once in a while. And you're like, okay, so you pull them back at the ER, you put them on an EKG and you see that they are in A-Fib. Now, when did they go into A-Fib?
You don't know.
I don't know. So what's our biggest risk here? Clots. So those clots are sitting where? They're sitting in the atria. So do I want to cardiovert them? No, because what happens if I cardiovert them into a normal rhythm and the atria are like
Those clots
everywhere. So what do I tell this man? Go home, sir. Okay. No, we will put them on anticoags for 6 weeks. Go home, take this warfarin, come back in 6 weeks, not through the ER, but we will plan it and they'll do a synchronized cardioversion. How is that different than defibrillation? What's defibrillation?
Shocking the heart.
Big giant paddles go boom, like in a code, right? Are we going to do that to our patients that are like, hi, my name is Mr. Jones. I've been having some palpitation. No. Synchronized cardioversion. Break it down. So synchronized means what?
To get it back into rhythm.
Synchronized means if I'm synchronizing with someone, that means we're kind of getting in the, yeah, we're getting in the same rhythm. And cardio means heart. Cardioversion means
It's like you shock them at a certain point of their rhythm.
yes, you are going to synchronize their heart rhythm at a certain point. So we take these teeny tiny baby paddles. This is a planned thing. Okay. They come in, they're like, hi, I've been on warfarin for the last 6 weeks. I'm probably going to check their PT9R, right? Check all their coags. And then I'm like, okay, we're going to plan to do this. They do not have to be intubated, sedated, nothing like that. Now you'll give them like a mild sedation because you are kind of shocking them, might hurt a little. So we just lay them down and they're going to give them a mild sedative. And then they put them on a continuous EKG and the doctor's going to watch at what point he needs to go in and do a teeny little baby shock. I mean, I've heard it kind of hurts, so I shouldn't say baby shock, but like, it's not the boom defibrillator. Yeah. Do you understand the difference between defibrillation, emergency code, big giant shock, the patient's practically dead? Yes. And synchronized cardioversion, planned, lovely. Here's some sedation, put on this lovely gown. You see what I mean?
Yes.
Okay. All right. So if you do not see them go into it, because I don't know how long they've been that way and I don't want to pump out clots the rest of your body, right? Let's say the patient comes in, they're like, I'm having like weird palpitations. You put them on an EKG, their EKG is just funky, right? So they get admitted to the observation unit for 24 hours. All of a sudden the telemetry goes off and it's like, hey, your patient just went into A-Fib. Then what do? You're going to call the doctor and tell them
They just went into A-Fib.
they just went into A-Fib. We need to do a synchronized cardioversion right now, right? I only have a short period of time before they start making clots, right?
Yes.
Do you understand what I mean?
Yes.
So if you see them go into it, then
Call the doctor.
call the doctor. Like we can go ahead and schedule this right
Now.
the hell now. Yes. Do you understand?
Yes.
Okay. And then these patients, if they're just living in A-Fib, when I give them, like take them home, well, I'm not taking them home, when I send them home. Yeah. That'd be weird. What antidysrhythmic would we normally prescribe? I heard somebody say it earlier. Amiodarone, because amiodarone is weed for the heart. So it's going to tell your atria like, hey, settle down a little. Okay. Anticoags for at least 6 weeks. Your other option would be an ablation. Do you know what ablation is?
Yeah, you like burn it.
You burn the little spot that's like causing it to go zzz, haywire, right?
Yes.
Right. Okay. That's a big surgery.
Yeah.
Okay.
It's like probably would be last option.
No, sometimes they can actually do it in cardiac cath. So sometimes they will do it. But yeah, that wouldn't be my first option. Agreed. Yes.
Yes.
Okay. Do we understand A-Fib?
Yes.
Okay. So in A-Fib, all you're going to see is teeny tiny little P waves, but QRSs are usually pretty good. They may be a little more narrow than normal, but usually they look rather good. Yeah. Okay. It is irregularly irregular, but if you look at the whole pattern, usually you can see somewhat of a pattern. Yes. Okay. All right. A flutter. What's our keyword for a flutter? That's a sawtooth. You all right?
Yeah.
It went down the wrong way, didn't it?
Yes.
You're going to cough for like 3 more minutes. I know that is awful when that happens. Okay. So I want you to turn over your pagers, if you had one. And if we went back to 1996. Okay. Did you say the 1960s?
Yeah.
Okay. Well, I had a pager when I was in high school, ma'am, and I was not anywhere near the 60s. Okay.
You always say you're old as shit.
Well, I do, but I'm not that old. That would put me at what? Oh my God, no, ma'am. Okay. So anyhow, well, y'all are really nice about my age. I appreciate this group very much.
Oh my God.
Yeah. Well, I won't forget it. You want to hear what she said about me?
Oh.
Okay. So I gave them assignment to do. Was it the insulin video? One of the videos on YouTube, and she comes in like all perky and everything. She's like, oh my God, I watched the video. I'm like, that is such great news. Because I like it when y'all actually do the prep work. So she came in and she was like, oh, I watched the video. When was that? I was like, I don't freaking know. My kid was like, Caden was little, like 6 or 7. So I was like, that was probably like 5-6 years ago. I don't know. And she was like, oh, really? You looked so young and you were so nice. Bitch, back up. She said that about me in front of my face. So anyhow, moving on. So if you want to look at what this looks like, they call it sawtooth. It looks like little shark teeth or something. Okay.
Yeah.
So it's more than a fib, because fibrillation is like a pager from apparently the 1960s where it's just like, zzz, right? A fibrillation, it's fibrillating. So it's going to look like this. Okay. Have you ever seen like on TV or something, somebody takes a lie detector test and it starts going like this?
Mhm.
Okay. That's what it looks like. It's like little waves. Okay. So you can see the QRSs have to be very narrow right now. Sometimes they may be normal, right?
Mhm.
Okay. But if you counted their ventricular heart rate here, what is their ventricular heart rate in this 6-second strip? That would be 80, right?
Mhm.
Okay. But their atrial heart rate is going to be like 200 to 400 because it's going super. How many P waves you got for every QRS? Like 4 or 5, right?
Mhm.
Okay. Now I'll turn it back over now that you've seen it. Okay. All right. What's their PRI?
You can't calculate.
I can't
it.
calculate because I don't know which P do I do.
Yeah.
Yeah. All right. QRSs are either, yeah, but they're normal or they may be a little bit narrowed. Yes, you're absolutely correct with that. Okay. Are they stable?
Yeah.
Yes. We're going to treat A flutter just like we treated A-Fib. What's your biggest risk from A flutter?
Clot.
Clot's not as big of a risk as A-Fib because it actually is doing something, right? Fibrillation is a bzzz, flutter is like a no. All right. So who gets a flutter?
Elderly.
Elderly patients can do that. Go on. Diseases of the heart. Okay, some heart
lung.
diseases, more lung disease.
Did OSA affect this too?
Yes. What about our heart failure patients? And heart failure, the ventricles are not able to pump well. So the atria are like, don't worry, I got you. So then it's like, zoom, zoom. You see what I mean?
Yeah.
Yeah. So it's like your body is trying, but then it like really sucks, you know? Okay. So what is your priority? What are you going to do? Same as
Clots.
AFib.
Anticoagulants.
So if they are new onset, like I see them go into it, then you're going to do
The doctor.
call the doctor and order a
Synchronized
synchronized cardio version. I said order it like we can just do that. And if you do not see them go into it,
Anticoagulants.
we're going to put them on anticoags for about 6 weeks and then have them come
For cardio.
back. And then we're going to do a synchronized cardio version. What drug will I probably send them home on? Amiodarone. You see how it's like the same.
Yep.
Okay. We also have the option to do an ablation if it's really bad.
Okay.
Got it?
Yep.
Okay. Next is SVT. What does SVT stand for?
Supraventricular
Supraventricular tachycardia. This is what kind of dysrhythmia? This is an atrial dysrhythmia, right? Because it's above the ventricles. Okay. So what's their heart rate going to look like?
Really high, like 250, 400.
At least over 150,
Okay.
right? Because the ventricles though are pumping
Fine. Relatively. Okay.
relatively okay. Okay. But the ventricles may try to catch up. So you may see, I mean, the heart rate's going to be high. Like you're still going to have more QRS complexes.
Mhm.
Okay. Because
Yeah.
it's basically like supraventricular tachycardia is very close to like atrial tach. Like, why don't you just call it that? Why do we have to do that? They called everything else what it's called. Do y'all see what I mean?
Yeah.
Okay.
The
Okay.
SVT sounds
So the heart rate's going to be more than 150. What's a PRI?
You don't know.
I don't know. Who knows? This one to me looks like a stair stepper, right? So if you look at it, it looks like you're like climbing up the little stairs. Do y'all see that?
Oh, yeah.
Because it's basically like beat. Yeah. Yeah. Okay. So your QRS complexes definitely less than 0.12. They could either be normal or they could be
More
narrowed. Okay. Is this patient stable? Yes, because your ventricles are still pumping off like normal. Now they may feel palpitations and they may feel like nervous or anxious because you're like, oh my God, my heart is like going crazy. Okay. But they are considered stable. Got me?
Yes.
Okay. What are the causes of SVT? Same ones as PACs.
Elderly.
Same ones as PACs. I did not say that. No. PACs. It's the same as PACs, premature atrial contractions.
Nervousness.
Like
Anxiety.
excitement,
Yeah.
anxiety, stress, and your atria are like, oh my God, oh my God, oh my God, oh my God, oh my God. So instead of having like one PAC where it's like a little excited, it's like the atria are like, so it's like, yeah. Okay, cool. So caffeine, nicotine, stress, anxiety. Yeah. Okay. What is your priority? What's the first thing you do when a patient goes into SVT? No, y'all know this. Y'all know
Adenosine.
this. No, it is a weird thing. And
They're
what's her
not
name used to
bagel
say it all the
fever.
time.
Bagel
Yes.
fever.
Okay. So the first thing
never
you're gonna do is a vasovagal. You're gonna tell them to
Put
bear
chest.
down as if they're having as if they're having a bowel movement. And
Yeah.
why are we doing a Valsalva maneuver?
Close breathing.
Right. Valsalva maneuvers normally cause bradycardia, which is why you're not supposed to push really hard to poop or you'll pass out on the toilet.
R.I.P. others.
Don't be that girl. Yeah. Okay. We're going. All right. So we're gonna do Valsalva first. If that does not work, what drug do we give? Adenosine. What's the dose?
6 milligrams.
6 and then
12.
12 and then
Immunotherapy.
12 again. Okay. So it's either 6, 6, 12, depending on your hospital, or 6, 12, 12. Right. What does adenosine do? Stops the heart and then restarts it and is like, let's just give this a shot. Kind of like when your computer goes bad and you just turn it off and
Restart.
turn it back on again. And you're like, oh my God, it works. Anyhow, so if that isn't effective, what are some other drugs we can give? All I want to do is like slow down the heart rate a little bit.
Amiodarone.
Maybe, but we usually won't because
Light
amiodarone's
things.
like, we want to use something very simple. What can
Beta
decrease our heart rate?
blockers.
Beta blockers or calcium channel blockers is usually what we'll use because they're not in like acute,
Uh-huh.
and we're not going to send them home on it because we can get them out of SVT.
Mhm.
Yeah. All right. We can also do a synchronized cardioversion.
Yes.
Pretty easy. Yeah. And just be like, boop. Mhm. If I can't really get them out of SVT or they keep getting runs of SVT, which can sometimes happen, I will send them home on amiodarone PO. Okay.
Yep.
Okay. Before they go into synchronized cardioversion, just in case they ask all this on an exam, we will sedate with either fentanyl or Versed.
Okay.
But they're not going to be like totally out. We're like just sleepy time.
Okay.
Okay. Do you understand SVT?
Yeah.
Yes.
Okay. SVT, what's our keyword? Stair stepper. Yes. A flutter, what's your keyword?
Sawtooth.
Sawtooth. A-Fib, what's your keyword?
Vibrate.
Vibrate, you pervert.
Pager.
Pager.
Yeah. Retro pager. Antique pager. Okay. PACs, what's your keyword? All right. Do we understand atrial dysrhythmias?
Yeah.
Okay. That was fun.